on the VIT circuit. And so Joy, with that wealth of experience, we really do look forward to hearing from you tonight. I'm going to hand over to you to start your presentation. Thank you so much.
Thank you, Tanya, for that introduction. So as you've heard, my name is Joy Fredericks. I'm a neonatologist at Rahima Musa Mother and Child Hospital. Thank you for this opportunity to present the neonatal resuscitation guidelines and what's new and the latest 2021 update. So I have no conflict of interest and nothing to declare. Sorry, I don't know why my screen's not moving. Okay, so by way of introduction, many of us know that most infants will adapt well to extrauterine life and do not need any help. Up to 90% will breathe spontaneously without any intervention. However, some will require some help. About 10% will respond after drying and stimulation and airway opening maneuvers. Approximately 5% will carry on and need positive pressure ventilation. And even less will need intubation and less chest compressions, and only 0.05% might need adrenaline. So we all know it's the inverted pyramid where most babies, all babies need evaluation at birth, but almost less than 1% will need extensive resuscitation. So even though 1% of newborns, only 1% will need some extensive resuscitation, we still need to be trained. We need to be appropriately trained to deal with difficult resuscitation. What's been happening in Africa up to this point, and I found this quite interesting when looking into the Helping Babies Breathe initiative. So this study was published in 2009 by Wall et al. They looked at, I think, 6 centers in Africa, and just to see what was happening at their centers. And they found, shockingly, that less than 50% of women actually delivered in a hospital facility. And even worse, less than 20% of those facilities were adequately equipped to deal with neonatal resuscitators. And even more shocking, less than 10% of these deliveries had a skilled attendant who could deal with neonatal resuscitation. So based on this came the 2010 call to act, where looking at this data, a response had to be made, and the Helping Babies Breathe initiative was founded. The vision being to reduce neonatal mortality rate due to birth asphyxia. The Helping Babies Breathe initiative is a global public and private alliance with the funders and sponsors seen at the bottom of the slide. So what was the Helping Babies Breathe initiative? It's basically looking at a simple set of skills that saves babies' lives, and trainees would receive a pack, or their facility would be equipped with a basic ambu bag, a self-inflating ambu bag, a very basic suction device. And all these devices didn't require electricity. In fact, they could be used at home deliveries and even in the absence of electricity. The course was designed for any birth attendant, doctors, midwives, and mostly directed at rural areas and for out-of-hospital situations. The focus is on the golden minute, the first golden minute, the first minute of life, and the initiative was to get babies to breathe. So this is just some of the algorithms they use, and by the 2015 report, they had translated the manual into over 20 languages, and it's available through open access as well. And again, this picture from the 2015 report, they had this Helping Babies Breathe initiative had rolled out in more than 80 countries, as you can see on the map, with South Africa also included. Again, a very basic, simplified algorithm. And again, like I said, designed for anybody attending a delivery, where it starts with assessing the baby, drying thoroughly, assessing if they're crying or not. Then if they are, keeping them warm, cutting the cord. And so basic care. And then if not crying, going down the algorithm to keep warm and clear airway, stimulate, and assist with ventilation with the ambibag. And then in red to call for help if those steps did not result in a breathing baby. So this initiative is mostly focused at getting baby to breathe. And when it moves on to down the algorithm to circulation drugs, there's an advanced course, but this Helping Babies Breathe initiative was focused mostly on getting a baby to breathe. So the initial steps of an algorithm. Okay, so how do we come up with official guidelines? So I've told you a bit about the basic Helping Babies Breathe program. They follow international guidelines as well, but we've all heard of the ILCOR committee, the International Liaison Committee on Resuscitation. Currently, they've got 7 council members, and we are represented by the Resuscitation Council of Southern Africa. And we're fortunate enough to have Dave in the next talk, who's the chairman of that organization. So ILCOR was founded in, I think, 1992, and their first guideline was introduced in 2000, and then every 5 years they subsequently have produced guidelines, international guidelines, when reviewing all these council protocols. And then each country would come up with specific guidelines for their region. So looking at the 2015 algorithm, the neonatal algorithm, versus the 2021 algorithm on the right. So remember I said every 5 years they released, the ILCOR guidelines were released a consensus statement. Unfortunately, the Resuscitation Council of Southern Africa were a year late in releasing theirs. I think we were all preoccupied with COVID. But when you look at the two algorithms with the 2015 and the 2021 on the right, there really is no difference. If you, besides the color font, and there really is no difference. And we're going down the algorithm, they're identical. So what 2021 guidelines basically reinforced the 2015 newborn algorithm guidelines for resuscitation. So I'm going to go through this in a little bit more detail, and then I'll also discuss what other committees are doing, like the European Resuscitation Council and the American Heart Association, and just compare it to our protocol as well. So all algorithms for neonatal resus have this orange line or this action line right down the graph, emphasizing that we have to maintain normothermia. So normothermia and temperature control is extremely important because effective thermal care reduces infant morbidity and mortality. Admission temperatures should be recorded as a predictor of outcome. So it's very important to document that in the baby's file. And we have to aim for a temperature of 36.5 to 37.5 degrees. We have to avoid hypo and the opposite, hypothermia. So hypothermia, we know, is associated with IVH in the preterm, respiratory compromise, hypoglycemia, and late onset sepsis. So even the opposite, hypothermia, in a term baby who has asphyxia, any temperature of above 38 degrees can double the mortality rate if the temperature is more than 38 degrees in the first 24 hours. So it's very important to maintain thermal control. In infants less more than 30 weeks, you want to dry cover and keep them warm, either with skin to skin or a radiant warmer. In a preterm baby, we do not dry, we wrap in plastic and we place under radiant warmer, as in the picture below. So, is there anything new about umbilical cord management? It's exactly the same as 2015. The aim is still to delay cord clamping for at least 60 seconds when resuscitation is not required. And then if resuscitation is required, you should consider still delaying cord clamping if you can initiate resuscitation safely next to the mother or in between the legs in an NBD delivery. When you cannot have delayed cord clamping and resuscitation is imminent, what they suggest is cord milking in infants more than 28 weeks gestation. Now, this is new because this wasn't in the 2015 guidelines. So cord milking is only for infants more than 28 weeks. It's not recommended for infants less than 28 weeks because there's an increased risk of IVH and an increased risk of mortality. We know delayed cord clamping has many benefits, so please enforce it if you can in your unit. Okay, so going down the algorithm, it's the ABCD principles of resuscitation, with A not only being airway, but also anticipation, anticipating a difficult delivery, and then sending the correct expertise to be present at that delivery. And then the A also includes a rapid assessment throughout the algorithm, B's breathing, C circulation, and D drugs, as we all know. So the initial assessment is to decide if it's a term gestation, is the baby breathing with good tone, and then the baby would get routine care with the mother. And if the answer is no to any of those questions, you'd provide warmth, clear the airway, dry, stimulate, and obviously not to dry the less than 30-weeker and to cover with plastic. So airway, still recommended is the neutral position. Ensure the baby is not in a flex or extended position. The jaw lift might be necessary for an extremely hypotonic baby. A jaw lift maneuver might be necessary. And then also the two-person method of securing an airway might be needed in a difficult airway. For example, if there's jaw abnormalities, Treacher Collins, disorders such as that, may need this specialized technique to open the airway. What about suctioning? As in 2015, suctioning is mostly still a no. For both the non-vigorous and vigorous infant born through meconium stain ILCOR, routine suctioning is not recommended. The emphasis here is to initiate ventilation as soon as possible. And if you're struggling to get chest rise and you're concerned about airway obstruction after following the algorithm and initiating positive pressure ventilation, you might then consider suction under direct visualization to clear the obstruction. But all in all, suctioning is not recommended as routine. Going down the algorithm, at every time point, you're doing a quick rapid assessment. For 30 to 60 seconds, you're asking yourself, is this baby breathing? Is their heart rate? What's the color? And what's the saturation? And that brings us to the next point that's debated quite a bit, is how do you assess heart rate, and what's the best way to assess heart rate? And as in the 2015 guidelines, ECG is still gold standard because it's the most rapid and accurate measurement. Within seconds, you have an accurate, rapid measurement of the heart rate. Pulse oximetry, though it is necessary because you're going to titrate oxygen depending on SATs, it's not the first go-to to get a good heart rate because it takes time. And in the first few minutes, the reading is inaccurate for heart rate. If you don't have a pulse oximeter or ECG, probably the next best thing is auscultation. But remember, it's also can be unreliable, inaccurate, And to get a decent count, you need to probably go at least 15 seconds. So it takes time. And palpation is your absolute last resort and absolutely actually not recommended, because it's extremely unreliable and inaccurate. So do not palpate the umbilical cord. It is unreliable. Going down the algorithm, you would ask yourself, is the baby gasping, apneic? Was their heart rate less than 100? If the answer is no, then we suggest CPAP for the preterm baby. But if the answer is yes, you'd have to start ventilating with room air for a term baby, and with oxygen between 30 and 40% FiO2 for a preterm baby. Okay, so our guidelines don't really go into much detail, but the European Resuscitation Council suggests giving 5 inflation breaths. The initial breath for a term baby being at a pressure of 30 centimeters of water, and obviously at room air for a term baby. And then the initial breath being at 25 centimeters of water for a preterm baby. And they suggest 5 inflation breaths of up to 2 to 3 seconds each. Also, the European Resuscitation Council and actually the American Heart Association also recommends a lower saturation FiO2 oxygen levels for preterm babies, where we're recommending 30 to 40%. They're recommending 21 to 30%. What about sustained inflation breaths? Again, there was a lot of hype about this a few years ago, and many studies were done looking at 5 seconds, 10 seconds, 15 seconds sustained inflation breaths, with the aim to actually displace lung fluid and for recruitment of alveoli. But all the studies have shown that it is not recommended, because there's an associated increased risk of mortality, particularly in the first 2 days of life. And this Floglia et al. Did a lovely study. I think she looked at meta-analysis of over 9 studies, and whether the term, preterm, 5 seconds, 10 seconds, 15 seconds, none of it showed benefit. So please do not do sustained inflation breaths. What about saturation transitioning? We know that the baby has to transition from intrauterine circulation to extra, and that takes time. And where we see this little block on the right of the algorithm talking about pre-ductal sets after birth, we know that this comes from a study by Jennifer Dawson, where she published in 2010 in Pediatrics, looking at, I think it was 470 babies, and watched their sats over the first few minutes and plotted them, whether they were term or preterm, and came up with these kind of graphs. And that's how we know that the sats have to progress slowly, and we want sats of more than 60 at 1 minute, more than 3 minutes at 70 minutes, and more than 80 at 5 minutes, and more than 90 at 10 minutes. OEJL et al. Also published some very important data, where they say that if a baby is born at less than 32 weeks gestation, you have to avoid sats of less than 80% and or bradycardia at 5 minutes, because that's associated with an increased risk of IVH and death. So please allow them to transition, but don't allow them to be hypoxic, because that's associated with increased mortality and death. So working in South Africa can be quite difficult, because not every unit has blended oxygen nor SATS monitors. So alternatively, the Resuscitation Council of Southern Africa has suggested a way to bag to get an O2 of 21, 40, and 100%. So when you bag without the oxygen attached, you're giving 21%, obviously. When you bag without the reservoir but the oxygen attached, you get an FiO2 that approximates 40%. And when you bag with oxygen reservoir and attached to oxygen, the infant will get 100%. And I would imagine that's why the guidelines suggest for preterm, starting with the FiO2 of 30 to 40, because many centers do not have blended oxygen and would struggle to give lower FiO2s than 40 if they do not have blended oxygen. So some assisted ventilation devices, comparing them. Again, ILCOR recommends using a T-piece resuscitator where possible, because it can provide continuous positive pressure. It can give you a PIP and a PEEP, and can give you a controlled environment where you have less volume trauma. But if you're going to use a self-inflating bag, be careful not to deliver excess volume. What about adjuncts, airway adjuncts? The laryngeal mask can be used in infants more than 34 weeks, or ideally more than 2 kilos as well. And where we can use it when there's ineffective mask ventilation or where intubation is not possible. And then intubation, tracheal intubation, can be performed at any point down the algorithm, but probably reserved for where you have ineffective face mask ventilation or prolonged ventilation. And also the algorithm suggests that when you start chest compressions, you should be considering tracheal intubation. And then, of course, don't forget intubation for special circumstances such as congenital diaphragmatic hernia. Moving down the algorithm to circulation, when the heart rate is less than 60, we start chest compressions, and the compressions remain 3 to 1, 3 compressions to 1 breath. And at this point, the algorithm says you have to increase the FiO2 to 100% and call for help. And the hand encircling technique is still the preferred technique over the 2-finger technique, as it gives better cardiac output. What about drugs? Going down the algorithm, adrenaline is still the main drug for resuscitation. When the heart rate remains below 60, despite adequate ventilation and chest compressions, the dose of 0.1 to 0.3 moles per kilo of a 1 in 10,000 solution is given. And this hasn't changed on any guideline. The dose remains the same. And that's an ILCOR recommendation. If, according to the Resuscitation Council of South Africa, if you cannot get IV access, then you can go for 1 mole per kilo adrenaline via the ET tube of a 1 in 10,000 solution. Also consider if the child had any bleeding, if you're worried about antepartum hemorrhage, correct hypovolemia, you can then give 10 moles per kilo of the normal saline bolus over 5 to 10 minutes. Also watch the glucose and correct if need be. What about sodium bicarb and naloxone? And since 2010, this has been off most guidelines. It's not recommended by ILCOR. We know sodium bicarb can impair myocardial and cerebral function. But some, like the European Resuscitation Council, actually says it can still be used, considered in a prolonged cardiac arrest. But it's not mentioned on the Southern African guidelines, and neither is naloxone. It's not supported by ILCOR guidelines. Don't forget post-resuscitation care to continue normothermia, but if you are concerned that the child might have HIE, then if facility allows, to induce hypothermia according to local protocols. And if it's a preterm baby, please consider CPAP and surfactant according to protocol, and maintain SATs between 90 and 95%. So when do we discontinue care? So ILCOR states that national committees should provide local appropriate recommendations, and besides PIP and saving babies, I'm not really sure of any local appropriate recommendations for when to discontinue care, but I can be corrected. Please feel free to comment in the discussion at the end. But ILCOR is recommending definitely, if more than 20 minutes of no heartbeat, you've got to stop resuscitation. If it's been more than 10 minutes and there's no heartbeat, at that point you can review, look at gestation. Is it a baby that's maybe non-viable? Are there dysmorphic features that might change the prognosis? And also to consider the views of other team members, and you might consider stopping at 10 minutes if there's no heartbeat. Now, when there is a heartbeat or incomplete improvement of heartbeat, this is a bit controversial. And I know first world countries might recommend that these babies receive ventilation and then withdrawal if the prognosis is guarded. And in our setting, that is not always possible. But definitely 20 minutes, no heartbeat, you will stop. When withholding or withdrawing, please remember that you have to follow appropriate palliative care plan for the family and the child, and you've got to be comfort focused to give the baby a dignified death. What about withholding resuscitation? Again, very controversial. It also probably depends where you work and which part of the world. But I think the consensus is where there's extremely high predicted neonatal mortality rate, you can withhold resuscitation. And remember, withholding and discontinuing are considered ethically equivalent. And then also probably you can consider withholding resuscitation where there's an extremely high morbidity rate. For instance, in a very preterm baby, less than 24 weeks, you might consider that. And when in doubt, always commit to 100% effort. And it's not the time to decide when you're uncertain. In the first few minutes of life, give it 100% effort, and you can decide on withholding or withdrawing down the line. Also, the guidelines, the international guidelines, emphasize team briefing and debriefing, and I think we neglect this. The briefing, importantly, before resuscitation, what is needed, who's going, so that the resuscitation is run very smoothly, and then debriefing, so we can learn from our mistakes and deal with any psychological trauma resulting from the resuscitation. Thank you. That brings me to the end of my talk.
Thank you so much.
Oh, sorry, Marty, you can go.
Oh, you go, Tanya.
Okay, no, so thanks, Joy. I think it's always reassuring to know that there's nothing dramatically changed from the algorithm and that there's an evidence base to support not doing extra things here. So Marty, do you want to tell us what's next? So, and Joy, if you don't mind hanging on for the Q&A, that's where the hard part comes in, I think.
Definitely. So Joy, please don't go anywhere. We'll make time for questions at the end. So I just want to quickly ask Andrew Redfern if he is on. He just wanted us to share this Power 2022 Pediatric Orientation Workshop and Emergency Revision course. So if anyone interested, I'm going to leave the slide there and you can get the contact details. While I don't know if Andrew is on, let me just see if I can unmute him. Okay, great. Andrew, do you want to quickly say something?
Thanks, I'm unmuted. Yeah, just want to let people know about this course. So happening in January next year, and the person to contact is Prinny Moodley, who's based at Paarl, which is a regional hospital in the Western Cape. But it's a 5-day course with local and international speakers covering a range of emergency topics. So we thought we'd let people know about it because we're doing sort of emergencies and resuscitation this evening. So all sorts of different pediatric and neonatal emergency talks and topics are covered. And it's completely free on the Microsoft Teams platform. So you can also just join for however much you are able to join. So it's an educational opportunity for people. Thanks, Marty.
Great. Thank you so much for that, Andrew. So with that, I'm going to stop sharing this and introduce our next speaker. who is Dr. David Clook. So he is a pediatrician and a pediatric intensivist, and also recently a pediatric cardiologist. He works at Chris Hani Baragwanath Hospital. He is definitely one of those overachievers that is currently the chairman of the Resuscitation Council of South Africa since 2019, actually. He is also the ILCOR Pediatric Task Force member, and he represents us there as well, and one of the co-authors of the guidelines. And then he's also a founder of the Barra Burns Kids NPO. And to fly this high, you have to be an adrenaline junkie. So he also enjoys a lot of sports outside of medicine. He's done the Ironman, and he's also accredited game ranger. So with that, I just want to really thank Dave for joining us tonight, and we can't wait to hear your talk. Thank you so much.
Thank you so much, Marty. That's quite an introduction. You say overachiever, maybe many others would say confused as to where can I just check, Marty, which screen is being seen?
Yes, I can see your screen. Thank you.
Okay, great. So yeah, as I say, thank you so much for that introduction. Yeah, it's an interesting talk to give over 20 minutes, but I just wanted to mention one or two things that Joy had to say, and thanks so much, Joy, for a superb talk there. That really was a great talk. I smiled when you put up our algorithm on 2015 and 2020 or 2021, and said that they didn't really change much because, as you say, you're spot on. And one of the reasons why we changed was people complained that the blue was too busy when trying to make photocopies and wall charts and what have you. And obviously, as you know, we don't really put a copyright on photocopying and that sort of thing. We wanted to get out as far as possible. So the neonatal team decided to then make it a lot simpler, a lot easier to put into textbooks, which I think this algorithm now is in the new Kuvadia that's coming out, and obviously much easier to photocopy and distribute. But one of the things, and as you can see from my slide, I've got 2010, 2015, and 2020. And in 2010, if you guys remember, there was a lot that changed there, particularly from 2005 to 2010. And then 2015, some subtle changes. And 2020 really has shown that we're starting to get it right. And I think that's really the take-home message here, is that there are subtle changes, definitely, but we really are starting to get it right in terms of the science that's come out and what we are doing. And so that's why I know, I mean, even being as intensivist, you want these changes. What are these golden bullets that are going to make outcomes so much better? And unfortunately, well, hopefully my talk's going to help towards that, to see how we can get better outcomes. And the surprise is going to be, it's the simple stuff. So let's get cracking. Oops, sorry. So my disclosures, yeah, very much the same. I don't have anything relevant to this talk other than for those people that don't want to do CPR, well then this is the wrong place to be, because being the chair of the RCSA, I'm very pro, and so advocacy is definitely part of what I'm all about. But you know, then I say that and I put this slide up, and as you can see, this is an old picture that basically was representing CPR a few years ago, where as patients arrived in the hospital in cardiac arrest, this was the sort of way that they left. So as they came in cardiac arrest, so they left a few minutes. We heard 10 minutes, 20 minutes in the neonatal talk, sometimes in coffins. And unfortunately, that is a sad reality. Many of you in the Cape know Professor Lee Wallace, a very, very acclaimed emergency physician professor of ours. And he brought up to me in 2010, I think it was, he said, Dave, in South Africa, should we really be doing CPR? And he raised some unbelievably important points, which again, sorry, coming back to Joy's guideline and algorithm story is, you know, these algorithms go through the whole of Southern Africa. And when you write an algorithm, you've got to make it clear and concise, but not over informative and controversial. And that's where we struggle with a lot of our algorithms. And so we really do welcome everybody's input, and that's what we're going to do. And in fact, that's my mandate for the next 2 years with the Resus Council, is to have groups within South Africa. Dr. Vidos Nakwe is going to lead the neonatal group as the representative of the Resus Council, but but I'm hoping Joy and all other neonatologists or resuscitationists that are involved in neonatal resuscitation from pre-hospital, in-hospital, ICU, to actually get involved. And if we need to tweak and we need to change and we need to do whatever's best for Southern Africa, let's do it. So what are the survival outcomes? And I'm talking globally here. And my disclosure maybe here is that I'm not talking about neonates. This talk is pediatrics with this principles that can be extended into adult resuscitation as well. And the sad reality is in 1960, it was 6%. 45 years later, and remember, we've done evidence-based medicine now for a little while, we only increased the survival by 0.4%. And so the real challenge is, what was the CPR survival rate in 2020? And the big problem was, and I'm sure many of you have seen my algorithms that I was forced to write in with regards to our COVID times, which perhaps is controversial and can be really scrutinized. What are our survival rates once we add in all the COVID statistics? And that really does put a dampener on the eagerness to do CPR, particularly out of hospital cardiac arrest. So being in Africa, and sorry, this talk has got a little bit of humor in it. Being in Africa and African, and when I do international presentations, one says, well, if us humans are only getting a 6% survival, how come the animals have it right? And yeah, you can see the seal gave the kiss of life to his handler in a Hong Kong oceanarium. But I mean, we all love puppies, and yeah, the puppy's giving the kiss of life. So if animals can get it right, why can't we? Not only on humans, but yeah, I'm sure to bring it closer to home. Many of you might remember this from many years ago, where a hippo saved an impala from, I forget whether it was a lion, cheetah, or crocodile, or was all of them. And the impala eventually woke up after that kiss of life, quite a serious kiss, and ran away. But Joy, thank you for alluding to this international collaboration, of which you said was all the resuscitation councils around the world. And perhaps not to repeat what you said, but I think the legacy that South Africa has is a group of people which was led by my father, in actual fact, Professor Walter Kloeck, who said his life goal is in South Africa. There wasn't a resuscitation council 32 years ago. And he said, we need to have one standard for resuscitation, just one standard. We're all doing all sorts of things. St. John's was a major organization a few years ago. Red Cross was a major organization in South Africa. And then the Heart Foundation was the other, that all did their own thing with regards to cardiac arrest management. And so his life dream, in fact, was to start in South Africa, have one voice, one goal, and one way of doing a resuscitation. And then, as you alluded to, in 1992, it started in a monastery in Utstein, where I'm sure many of you have heard the Utstein template on CPR or cardiac arrest reporting. They got together, and he got together with other members around the world, formed this ILCOR association, where now every single paper that has ever been published has been reviewed within the various committees on ILCOR and then distributed to the various councils to then make their guidelines. So Joe, you were quite correct. You said we started 2005, 2010, 2015, 2020, and now we're actually, because of our ability to do all this online platforming, safe online evidence evaluation that's protective and all the rest of it, it's moved to a yearly review. And I really encourage everybody to read these two papers. If you haven't read the 22 executive summary, I forget how many pages it is, probably about 17, 18 page document. And then this latest one that was brought out in circulation for this year's science and treatment recommendation updates, which I think is about a 77-page document, so nice bedtime reading tonight, on all the updates with regards to the various task forces, pediatrics, adults, basic life support, education and implementation, first aid, etc. And so every year it's going to come out. So it's an ongoing and a continuous evidence evaluation. And I think, Joy, you kind of alluded to it as well. We wait 5 years and then we're behind. And so this is the way that now, hopefully, everything that is published within the last cycle will be looked at, decided on whether it needs to have a systematic review or just an evidence update, and then brought out in these various documents, which will be published every year. So many of you probably remember this table, which is a 2015 table. And again, in 2020, we've just highlighted the importance. And I want to highlight three things. The first one was push fast. At least 100, but not greater than 120. So before we used to say that everybody was pushing way too slow. Now we're saying you need to speed up. And I'm sure many of you know the staying alive on the Bee Gees beat, which is exactly 100 per minute. So we're saying, you know, play that in the back of your head and while you're doing compressions, and that will give you your fast rate. But remember that cardiac filling, that preload, which is absolutely the first component dependent on developing a cardiac output, you have to, it's a passive process. And so you can't push too fast, otherwise you don't get any return. So push fast, but not too fast, and push hard. And we've got the various guidelines. Now, many of you go, okay, that's great, Dave. How am I supposed to push 4 centimeters in an infant, 5 centimeters? You know, I haven't got a measuring tape or a ruler that I'm putting next to the chest. And you're quite right. And we found that people were pushing too gently. We were tickling the chest basically in pediatrics because we're so scared of creating an output by pushing too hard. And I want to share something that I actually was involved in last week, which I'll share in a slide or two's time. But the point is, we mustn't tickle the chest. You've got to push hard. You've got to create an output. And these are the real core elements of what we call high quality CPR. And then the third element was we breathe too fast. And I challenge every single one of you to go back and have a look at cardiac arrests that have been performed, particularly in intubated patients, where we just bag and we bag and we bag. And then when I challenge you to look at the bag valve resuscitator that you're using, many of them probably have tidal volumes of about 250, 500. And if you're using an adult one on a pediatric patient, which you can because they have Poppel valves, many of them, you're using a 2-liter bag. And many of us compress with 2 hands. We compress with our full one hand. And I mean, my hand will then put 500 mils tidal volume in a 5 kg child, where actually the tidal volume ventilation is only 6 mils per kilo. So many of the times we breathe too fast and we breathe too much. And again, we increase intrathoracic pressure and decrease their venous return. So many of the times, are our outcomes because the child was so sick, or was it because we weren't actually doing the elements of high quality CPR, which I know many of us kind of go, oh, high quality CPR, yeah, that's for the BLS providers. You know, we the doctors, we the intensivists, and we do the fancy stuff, the drugs and the intubating and all the fancy stuff. We look at rhythms and try and reverse the causes. But actually, if you don't do the basics, that's why we're sitting at a 6.4% global survival rate. And is there data to suggest that what I'm saying is critical? Absolutely. And this is where it came from, where the guideline changes in 2015 and reiterated in 2020 happened, because you can see pushing return of spontaneous circulation, 1-day survival to hospital discharge, all dependent on pushing deep enough. Again, here was a feedback device that looked at, and here I want to bring your attention to the last block, which was good neurological outcome, because in actual fact, and that was a big change that we did in pediatrics, particularly from 2010, 2015, and 2020, was what are good outcomes? So we used to say, and many of you probably know, when you do systematic reviews, you've got to rate what are the most important outcomes you're looking for when you do a systematic review. And so ROSC, well, you have to have return of spontaneous circulation. But actually, no, that wasn't important. It wasn't important whether you get ROSC. It wasn't actually important whether you got to an ICU. It wasn't important if you got discharged from the ICU. What the critical outcome is are you returning that child with a good neurological outcome 180 days post-hospital admission, or even up to 1 year post-hospital admission? And in fact, there's last year we released the Pediatric COSCA document, which is basically reporting out of hospital cardiac or in hospital and out of hospital cardiac arrest outcomes with the specific emphasis on long-term neurological outcome, because that's really what determines a good outcome from cardiac arrest. Obviously, all these other things have to happen, but a good neurological outcome. And you can see there the percentages between those that were compliant, in other words, greater. This was an adult study, so greater than 5 centimeters, versus those that tickled the chest, that didn't compress deep enough. And again, chest compression rate. You can see there's the sweet spot, and that is between 100 and 120. Sorry, before I go on to this paper, just with regards, so last week I was involved with one of our drug companies one of our equipment suppliers that brought a chap out from Egypt, and they were taking, now this is what is the incredible part of this, not study, but just what they wanted to show about CPR feedback devices. And so we would use only healthcare professionals. So they were healthcare professionals in the ICUs at Moore Park. They were pre-hospital providers from all of our private services, as well as our government services, advanced life support providers. And we got them to go on a mannequin, and they made them do CPR without feedback devices. And then we made them do CPR with the feedback devices and put it on a graph. And unfortunately, I'm not at liberty to share those graphs in this particular presentation, but it's a study that we're probably going to do next year throughout the country to actually show the usefulness of feedback devices. And out of 56 people, between that 5 to 6 centimeter range and at 100 to 120, only, I think if I counted correctly, only about 17 out of 56. Now, those are all our top trained resuscitationists, got their depth and their rate correct without a feedback device, which is actually quite frightening. And in fact, the majority of them were pushing too fast, which is also interesting because we've been pushing this push hard, push fast, push hard, push fast analogy amongst our basic life support teaching. And obviously what we're doing is we're then taking it too seriously and we're pushing too fast. So, so sorry, maybe I'll come back to this. No, I'll start with the slide. So this was a paper that was published in 2004 by two very good researchers in resuscitation. And this was the whole thing around breathing too fast with too much tidal volume, calling it death by hyperventilation. And this sparked the further data that was done with regards to slowing down your breathing and making sure it's just enough to make the chest rise, no more. And so in 2010, you can see that in terms of ventilation rate, we then said that there was insufficient, and this is, sorry, it's a busy slide, but it's just copied verbatim from the recommendation, that treatment recommendations would encourage the reasonability of providing a minute ventilation less than normal for age because your cardiac output and pulmonary blood flows, in other words, your demand is less than normal during CPR. However, you notice that there was a change, and this was because of, in the 2020 evidence update, there was a small, and it is controversial, and if you've been following Medscape, and I think some of the emergency medicine bloggers, you'll note that there is this controversy around the airway or the ventilation targets in pediatrics, but the change in guideline was because of this RCT that was done, where they showed improved survivals with higher rates, so 30 per minute in infants and 25 per minute in children. So in other words, that affected change in our algorithm, and this is our advanced cardiac arrest algorithm, where you can see in an infant that's not breathing, you should breathe once every 2 seconds, where we used to say 3 to 5, and in a child once every 3 seconds, where we said again you could go up to 5 seconds in that child. So in other words, breathing faster. Doesn't mean more though, it just means the rate might be improved, but it is controversial. But again, you can't, when you look at the data, you've got to plug it into to all the studies and then see whether there's a reasonable recommendation to change. And that's the current change, is that we increase our respiratory rates in either intubated or children that do have a pulse but are not breathing. Okay. So then there's the other controversy, which many of you probably know we've already been talking about, was this whole CAB and ABC sequence. Now, granted, this had a lot to do with adults, and still, as much as we know children are small adults, we still extrapolate a lot from adults. But I just want to highlight some of the data. And I think, again, one needs to go back to the environment we're in. How many of us are going to do mouth-to-mouth ventilation on the majority of arrests that we have? Now, I'm not talking about our family, and God forbid, family events where there's an accidental, non-fatal drowning or something like that. But in our workplaces, in our day-to-day lives, wherever we are, clinics, etc., how many of us are going to do mouth-to-mouth breathing? How many of us have pocket masks inside the back pockets, or in our whatever our doctor's cases or sisters' cases are? We don't. So you're going to have to go run for a bag, get a mask, and then get a seal and start your rescue breathing. And again, the Americans and the Europeans disagree on whether you should give 5 breaths first for a child, or whether you should even start with 1 to 2 breaths in a child, or start with compressions only. And our feeling was there's 18 seconds. If you're doing high quality CPR, there's an 18-second delay between starting compressions and giving your first 2 breaths. Is that, particularly in the witnessed arrest, is that going to influence your outcome if we had to take an ABC versus CAB sequence? And I leave that as an open-ended question. But the point is, I think if we put it into our reality, that's why we as Resus Council have gone for the CAB sequence. Like I said to you, with regards to developing algorithms, keeping things fairly standard across the board, so that people, our CPR knowledge is horrific as it is. And our compliance to high quality CPR is absolutely terrible. And so now we want to add in lots and lots of different subtleties. It may not be the right answer for Southern Africa. So we chose the CAB, and I'll explain to you partly why we go for that. But as I said, and we're going to be doing this in the next year, we're going to be looking at a Southern African consensus as to what should we do, CAB, ABC, and with children particularly, should we be doing a sort of stacked sequence of breaths or just 2 breaths and then continue with cardiac arrest, your normal cardiac arrest algorithm. Now this is what I was getting to with regards to, and this is an example of what we call quality CPR or feedback CPR. So in other words, this is a machine where a lot of our pre-hospital providers, private pre-hospital providers, and in fact our government services in our major centers have these devices where you can monitor your CPR quality, you can monitor your CPR rate. They have entitled CO2 monitors, which also we know in 2015 and backed up in 2020 also improve our quality, of CPR. And so the consensus was, and now, sorry, I alluded to this a little earlier, from what I've just done in the last week with regards to the 3 sessions we did, I think I'm going to be pushing this study next year. So we'd love to get as many centers involved and actually prove that CPR devices linked to our machines improve quality, and it's quality that's going to change outcome. And so you can see that the consensus from the PALS task force was to actually use these devices. And you can see from the graphs, now this is old data already, but you can see how it improved rate, it improved depth. CC fraction is your compression fraction percentage. In other words, of the total time you were doing CPR, how much of that was actual compressions and quality compressions. And the reason why we look at that is, remember that you create a cardiac output and you create a mean arterial pressure that can be about 70% of the normal mean arterial pressure. And in a body that's dead, essentially, the rest of your organs, your muscles and your stomach and your gut and all the rest aren't actually using that much oxygen. So supplying the major organs should be okay. So you want to have that chest compression fraction as high as possible. You don't want to lean on the chest because, as we said, you need the chest to refill or the heart to refill. Preload is critical. And if you got all 4 of those, you got this excellent. And you can see without feedback, 1% versus 70% of achieving the targets if you had a feedback device. So really, it's something we should be looking at. Continuous waveform capnography, I think everybody hopefully has seen this from 2015, and Bruce has reiterated that this definitely does help with improved CPR quality. And instead of then wasting times off the chest, always trying to feel a pulse. And as we know, as resusces go longer and longer, we start feeling pulses more and more regularly because it must come back, it must come back. We're getting tired and it must come back. And in fact, we shouldn't be doing that because we're just dropping that high quality CPR. So entitled CO2 with an acute spike over 40 may be suggestive that we have return of spontaneous circulation. And this is an old slide as well, but it still holds so true that early defibrillation, so if it's a shockable rhythm, shock it, and high quality CPR are so much more important than intubation and drug therapy. And I want to show you the old data for those that didn't actually see this. 11,000 patients in Sweden. You can see those that got adrenaline actually did worse than those that didn't. And the reason was, it's an old study, so our guidelines weren't identical. But the point was that people wasted time trying to get lines up. Intraosseous in the time of this study wasn't a huge factor like it is today. So granted, we're not comparing apples with apples, but you can just see what we're saying is that if you start looking at other things than maintaining high quality CPR, your patients are not going to do well. And you can see the same thing for the intubated patients. This was an incredibly interesting study, and I'm certainly not advocating this as the way we go. But in Arizona, they did CPR pretty well. I think their survival rates of out-of-hospital cardiac arrest were about 15%, I think, if I remember correctly. And they said, well, because we can respond to scenes within 3 to 5 minutes, there's sort of a fire truck and an ambulance and whatever on every street corner in Arizona. They then decided in that initial first phase of cardiac arrest, they'll do 200 compressions. So you didn't even think about ventilation. You did 200 compressions, analyzed, if it was shockable, give a shock, followed by 200 compressions. The only way that they got oxygen was by a non-rebreather face mask and oropharyngeal airway. And then after 6 minutes, if there wasn't obviously a change, then they resumed with the normal algorithms. So I wish this was an interactive talk, because I'd pause here and say to you guys, what do you guys think? If our global outcome is 6.4%, what do you think these guys did? Now, they were already doing it well. They had a 15%, or I think it was 12 to 15% survival to hospital admission. And surprise, surprise, ridiculously, they went up to 48% survival figure. And so just reiterating that high quality CPR, going with those compressions, getting perfusion, especially if in the acute phase of the cardiac arrest, there already is oxygen, enough oxygen in the blood. You're not dependent on oxygen at that point in time, and you're dependent on perfusion. And that was an incredible study. So once again, old data, but over 1,200 patients, looking at those that got drugs, adrenaline particularly, versus those that didn't change. There was no difference in survival outcome. The second study from Teresa in Denmark, also no difference in outcome. And so we should be very, very careful about the first thing that we do is running for adrenaline, running for drugs, running for lines, running for things, unless you're reversing a course. Then that's obviously a different story. But in terms of just being part of an algorithm, that is the least important. Then we come to the therapeutic hypothermia, and we know that there was data that said everyone should be cooled. And this was beneficial for comatose patients following return of spontaneous circulation. And where did it start? Well, this was 20 years ago. The HACCR trial was a European study, and the Australian study was the Bernard study. Both of them published months within each other, and they were slightly different protocols, as you've seen. But what did they show? And just have a look at the difference. Survival outcomes significantly improved. That was in the HACCR trial. In the Bernard study, the same. What about good neurological outcome? I said to you guys that was a critical endpoint. In cooling patients on the Bernard study, significant improvement in neurological outcome, as well as in the Bernard study. So that is what we did for many years. And how to cool, and that was also now a controversy because we're not in these first world centers. I was thinking about Joy, the way she was talking about outcomes and post-ROS care, and many of these centers are focusing heavily on ECMO and ECMO CPR or extracorporeal CPR. We're not even close to well, one or two of our centers in the country are doing that, but on the whole, we're far from that. So using these kind of external simple cooling ideas is certainly something we can do. If we start getting a little bit more resourceful, then we get the more fancy in cold intravenous infusions of 4% saline or lavages, extracorporeal cooling, intravascular heat exchangers, critical blankets, etc. And then there were lots of controversies on now how soon to cool. I remember attending the European Congress in 2016 or 18, I can't remember, and they were talking about cooling in the cath lab before you even got ROSC. So now how do you declare a patient dead when we say you have to be warm and dead, but now you're cooling them before you even get ROSC? That's quite controversial. How long to cool and how quick to warm? And we know there's one of our intensivists, I'm sure many of you know, Miles Bartlett at Garden City. I'll never forget he's one of the probably got the biggest cohort of drowning patients, and he has some unbelievable outcomes from his cooling data. But he said, he quite categorically states that his biggest trouble is knowing how to warm. And sometimes that negates his entire cooling process, is the reperfusion injury that occurs in the rewarming phase. So there are lots of controversies. Not only that, we then had this data in 2013 around all the RCTs and the non-RCTs on hypothermia versus normothermia. And sorry, I think I'm probably pushing on time here. So just with regards to the latest trials, I'm sure many of you heard of the THAPCA trials. There was an out-of-hospital and in-hospital cardiac arrest arm. In adults, the latest was the TTM1 trial, and then below was released this year, the TTM2 trial. And just to remember, THAPCA, very similar to what I presented a little bit earlier, core temperatures of 33 degrees was the hypothermia arm. They were rewarmed over 16 hours to normothermia. And what is critical here is that all these patients, no matter which arm you went in, you were aggressively normothermic for up to 120 hours, in other words, 5 days. So that was the THAPCA trials, the TTM2, which is the latest one in adults, again, 33 degrees with controlled rewarming versus normothermia. And you can see that the same as what was published in 2013, and the small studies, even over the last few years, up to these two big ones, haven't shown that therapeutic hypothermia by these studies, meaning coming down to 33 degrees, did no better than aggressive normothermia. And so the 2020 guidelines, I'm sure many of you have seen, allow for both the cooling as well as the normothermia. But the biggest thing is avoiding fever. Fever must be aggressively controlled, so much so that your critical blanket is still indicated. But you're not setting it at 33, you're setting it at 36.5 or less than 37 degrees. And so we've just released this now, probably about 10 days ago, And I think this is sometimes where people have frustrations with ILCOR because it's all about wordsmithing. But I think if many of you have been involved in these international committees and scientific reviews with systematic reviews and meta-analyses, it's all about the way you word things. So actually, just like Joyce said, our algorithms haven't changed. So the PEDS recommendation hasn't changed other than to promote aggressive normothermia because of all the difficulties in hypothermia, but obviously cannot support or refute the induced hypothermia in children specifically, because all of those were adult studies. And so we've acknowledged that there are knowledge gaps, and certainly if there's more data, then this may change. Post-resuscitation care, critical. We love SATs of 100%. So now your child's back, they're in the ICU and they're on a ventilator, and we now go for our cup of tea and probably a clothing change because we're sweating and all the rest of it, and we're happy with SATs of 100%. And just remember that in an injured brain, or actually an injured organ system body, that hyperoxia, where your PaO2 is excessive, just increases free radical damage and increases the risk of secondary injury, which is what we're trying to protect in the post-resuscitation care. So remember, SATs of 94 to 99, don't let your SATs go above 100%. You don't need to. A colleague of mine at Children's Hospital, Pennsylvania, and this I just wanted to show in terms of pediatrics, when we brought out these guidelines 2010 and 2015, they took it so seriously that you could basically be fired if you weren't CPR compliant in their hospital. Now, imagine that at Baragwanath Hospital, being fired because you didn't do good CPR. I'm not sure that'll ever happen, but that's how seriously they took high quality CPR. And the critical thing here is look at what, now they one of the top, in fact, they were the top 3 children's hospitals in the world. And they still had an 8% improvement in good neurological outcome by enforcing the high quality CPR via simulation training and just making sure everybody every 2 weeks passes an electronic test that makes sure that their CPR is up to scratch. And the point I wanted to make, and this I guess makes also an interesting fact of when to stop CPR, because their downtime, they had a 12% survival to hospital discharge in children that had CPR for greater than 35 minutes, which was as good as those children who had CPR for less than 10 minutes. In other words, proving what? That high quality CPR, doing it properly, perfuses the brain, and you keep the brain alive, and you allow for a good outcome afterwards. So it changes things. We certainly can do prolonged resuscitations. And I know we know in our toxidrones at Baragwanath at the moment, we're having a whole host of calcium channel blocker overdoses. We know that those are prolonged resuscitations. So those with high quality CPR could still have good outcomes, provided, and those are way longer than 35 minutes at times, provided high quality CPR is being done. I wanted to show you here, now this is a little bit of an adult thing because we don't see ventricular fibrillation all that often, but just the point again, why we do chest compressions. And again, let's just have a look, and for those non-cardiac people, what happened was this is ventricular fibrillation over 5 minutes condensed into 10 seconds. And I hope everyone is seeing that the heart is busy dilating. So in ventricular fibrillation, the heart dilates. And it's this area here that's dilating more than this area. And if everybody remembers the anatomy, this is the right ventricle, this is the left ventricle. What do we know from normal cardiac physiology? If your left ventricle is empty, you can shock it as many times as you want. If it says shockable rhythm, it won't pump. It has to be full. It has to be stretched. The actin, myosin filaments need to be stretched open so the calcium channels are open, that when they then are shocked and the stimulus comes through as a coordinated beat from the SA node, it's got something to pump against. So that's the reason why we took away stat shots, and we don't want to ever see shock because the rhythm looks like it's shockable. If it is shockable, you shock it and the heart doesn't respond, there's a good chance that the left ventricle is not filled because of this phenomenon that I've just shown you here. So this is why we shock once if it's shockable. If not, get on the chest, do chest compressions, empty the right ventricle, fill the left ventricle, and then reevaluate after 2 minutes whether a shock is indicated. So in summary, despite 50 years, or now actually 60 years of active research, only 3 interventions still have shown to save lives, and that is early high-quality CPR. All of us can do that. Early defibrillation, all of us can do that. And early correction of the reversible causes, which we'll get to in a second. So I just wanted to share the one stat, and I hope everyone has seen these AED stickers around the country. Why are we allowing the public, anybody? No, you don't even have to be trained. If you see an AED on a wall and somebody collapses, you can put it on them and potentially shock them if it analyzes and says there's a shockable rhythm. Why is that allowed? because the statistic is if you can shock a sudden unexpected arrest within 30 seconds, you have a 97% chance of converting that rhythm to a spontaneous perfusing rhythm. That is what changed. That is what made the world go under AEDs. We only had about, just before I get on to the next slide, we have to commend Zimbabwe, because Air Zimbabwe, together with Qantas, were the first airlines to have an AED on every commercial flight. Why are we commending Zimbabwe? That's because they only had one international flight, so they only had to buy one AED. But here's an example of Chicago O'Hare Airport, and I think we had something like 20 or 30 AEDs in the country when AEDs first came out. They already had 260 AEDs in their airport. You walked 30 seconds. You were no more than 30 seconds away from an AED, and they found that that's still too little, so they've doubled it. If you go into Chicago Airport now, I think they're in excess of 500 AEDs in that airport. I challenge Gauteng to even see if we've got 500 AEDs in Gauteng. Just to finish off, we said contributory causes, and I think this is where some of these questions, I know, Joy, you in your talk was, how do we know when to stop? Well, you need to make sure that you've reversed everything you possibly can. I think that's one of the important points. And so we talk about the 5 H's and 5 T's, or the 6 H's and 6 T's if you follow the South African Advanced Life Support courses, and that is going through and making sure that you've reversed everything you possibly can. So in summary and ending off this presentation, now that we've gone through the data, we've actually become quite learned. We know what to do, high quality CPR. We can now go back to the animals, and here's in South Africa, in Weenan, at the Tukela Game Reserve, here's a child giving a baby elephant mouth to trunk. I'm not sure how many of you love your snakes, but here was a kiss of life given to snakes, and koi are quite expensive, so you don't want them to die either. So in Belgium, in Brussels, they did mouth to mouth on koi. Everybody loves the little pig babe. He got the kiss of life as well. And so much so that, look, I'm not sure about high quality CPR in terms of compressions on a tortoise, but certainly you can give a tortoise a kiss of life. Everybody loves a Dalmatian. And here was a paper an article published in Benoni where mouth to mouth was given to their Dalmatian, and it was one of our campaigns a few years ago. CPR worked for me. So with that, thanks so much for your time and attention. I apologize if I went a bit over time. Thank you.
Thank you so much, Dave. That was great. We are now going to go over to our panel discussions. So I want to introduce 2 of our panelists, so Dr. Shamil Sali and Prof. Mignon McCulloch. And I'm very grateful for them joining us today, because we are going to have some discussions around the more difficult ethical questions that we sometimes come up with after a resuscitation. So Shamil and Mignon, I want to ask you the first question. I know, as a group, as all 4 of these speakers today, you have saved many lives. And I want to ask if there's any kind of special trick that if you get to a resuscitation, is there anything specific that you immediately feel is extremely important to take over and to do 100% correct? Or is there certain tricks and things that you believe makes it different to get return of spontaneous circulation?
Hi, Marty. Is Mignon on, or do you want me to have a bash at this one first?
You can go for it.
Can you hear me?
Yeah.
Hi, Marty. So, I think when you come to a resus, the thing that strikes me usually is there's usually chaos. Sometimes it's controlled chaos, but there's usually a lot of scurrying around. There's usually a lot of activity. So I think probably the thing that I think is most important is actually just to have somebody take control of the situation, somebody to direct and lead the resuscitation, to have a team leader. And I'm always often drawn into doing things. All of us want to put in the work, want to get onto the chest and do things, but I think it's important to have a senior person take a step back and be the conductor of that resuscitation. And just know, and then details, as to, is there anybody that knows what's wrong with the patient, who the patient is? Is there some medical history as to what caused the arrest? Things that, I think we've gone through algorithms and structure, without getting into debates, but in pediatrics, I think a lot of resuscitations, a lot of kids have cardiac arrest secondary to hypoxemia. And often I find that if you can breathe for kids, if you can oxygenate them, your heart gets going. So if you're in hospital, I think making sure that you're breathing adequately and oxygenating is important. And as you're going through your algorithms, tick off the H's and your T's mentally, what's the glucose? And I find that, there's so much cutting around, but getting a glucose, making sure that this child isn't hypoglycemic, for me makes a big difference. Things like a timekeeper, knowing when we started, as to what's been done. People often come to me and tell me that they've done 8 cycles of CPR, and I'm saying, what's that, in terms of time? But when we know that we've started a cardiac arrest at 18:11, we're 7 minutes into it, we know that we're doing pulse checks every 2 minutes, we know we're giving adrenaline every 4 minutes. So I think time for me is vital in terms of knowing where we are in this resus, as to keeping track of interventions, keeping track of the length of it, and when we need to be thinking, should we potentially be stopping? I think for me, if we're in an ICU and we've got an A-line in place, adequacy of chest compressions, looking at an A-line trace, looking to see what pressures you're actually generating, for me makes a huge difference. So just making sure that you're actually getting an adequate cardiac output. So I mean, maybe
those are great points.
Yeah.
Okay, Minyo, you want to add?
I do. Shamil's got all the best ones, but I agree completely. You need controlled chaos. So you just need to calm things down. And for me, having trained at Barra as a very junior doctor, that was a good place to learn about controlling chaos. But if something doesn't make sense, always just go back to basics. So often if you're busy bagging a child and they're not going pink, just check that the oxygen is connected and it's actually switched on. So it's the real basics. It's much easier resuscitating a child in an ICU or in a high care than somewhere outside of that, and I always find that difficult. It's really anxiety-provoking resuscitating an adult in a shopping center. So those are things for me that are, it's going back to basics. And I think APLS, so we use APLS, going through the ABC again and again in your head just to make sure you haven't forgotten something. And then the question I've actually asked Joy, and I'm going to ask Dave as well, is, what about the family? What about the parents? How do you feel about having a family at a resus scene, and who's looking after the family? Because often it is chaotic and your priority is to try and save the person who's being resuscitated's life. But I think it's also just about doing less damage to whoever is watching. And I don't mind having people watching resussing, but you just need someone to look after them as well. So I'd be interested to know. Joy said she doesn't mind. Dave, I'd be interested to hear what you feel about having a family at a resus scene.
Yeah, thanks so much for that. Is a superb question. And so apart from my personal view, the Americans have actually, in fact, part of the PELS program is a video where they talk about breaking bad news. And one of the elements that they highlight on it, because it obviously is something that's quite controversial around, is allowing the family the option. I think that's the point, is allowing them the option. And so we know we sometimes aren't as resourced as the Americans are, because, as you guys know, we try and punt this team approach. And so they allocate a person to stand with the family and then not let them watch alone, because that can be quite scary. There's someone there standing, actually talking them through what's going on, what they're doing, so that when you counsel, and we know many of our outcomes are terrible, and we have to stop. When you then say we have done everything, the family then actually understands what you mean by we've done everything, because they've actually seen and they've gone through it. But the point was emphasized that if a family doesn't want to be there, we mustn't force them to be there. It must be a choice, but certainly to encourage. If it's not for the whole time, which it doesn't need to be, at least some point where there's a visual look at what has been done on the child actually makes the grieving process for the family, and that's well proven. Very important. Now then you asked me, and you just said about being at Barra and certain resusces, the chaos that goes on, and sometimes we don't have team members and we're struggling with people and it's only 2 or 3 of us trying to do the resus. Yeah, we could do more damage than good. So there it does become quite difficult. So I do definitely try, but I try and have somebody, and again, it needs to be somebody who knows what's going on and can be compassionate with the family. So those are some of the elements that are important with regards to family presence in cardiac arrest. And so if I can just, Shamel said some really, really great stuff. And talking about the team approach, the Americans now have actually added on, now it's all lovely to say we need 7 team members in a resus and everyone has a role, up to 7. Now, again, in South Africa, how many times we have 7? And they've added on an 8th. And that 8th person is a CPR monitor. You know, Shamel, you were saying we need to make sure things are going right. And that the job of a CPR monitor is, that's all they do, is make sure high quality is going on. Now, we laugh because, I mean, who's going to do that in half of our resusces? But I think the point's made, like you say, if it's done right, then maybe it's easier to then have your boundaries as to when you're going to stop, because you know you've given it an absolute 100% effort. That was the one thing. I'm sorry, and I've forgotten about the second comment I was going to make.
I think that's great. Thank you so much. I also agree that I think the team approach and having it more controlled, and for you as the leader or someone to say, I'm taking the lead, I'm actually standing back. So I think that's great. And I'm going to ask Tanya to ask the next question.
Okay, so we've got a couple of intensivists on our panel, but Dave, you alluded to this. There's a question in our Q&A about suggesting the CAB versus the ABC for an in-hospital versus out-of-hospital approach. So perhaps one of our intensivists can expand a little bit on that. Also, if Joy, you want to hop in, because somebody's also asked, is it appropriate for a neonate, a CAB approach rather than ABC? So I'll hand over. I'm not sure. Maybe Dave, do you want to start?
Well, it depends if you're in the north of the country or if you're in the south of the country. And because the Americans and the Europeans differ, and I said I sort of alluded to it in the talk a little bit, but that is a good question, and I think, like you're saying, you're giving some circumstances. So let's paint the picture. If you don't have and you're talking about in-hospital cardiac arrest, a bag mask device next to the patient. And you're an intern walking in because you're doing a blood gas and the sister calls you to do a resus. Are you going to not do anything and run for a bag first? Or should you start jumping on the chest and getting someone to bring that bag for you? I would advocate for jumping on the chest. So in other words, the CAB approach. But in saying that, in hospital cardiac arrest, in the ICU, where we should have all of this sort of stuff prepared, you know the arrest is an hypoxic arrest because the first 10 causes of a cardiac arrest in pediatrics generally are hypoxia. Well, then we know that oxygen is critical. So if your arrest is hypoxia, you need to get oxygen in as fast as possible, in which case then absolutely start with that. So I guess I'm not giving a straightforward answer, am I? I'm kind of saying it depends. And as I said to you, if done correctly, you're an 18-second delay whether you follow a normal CAB versus ABC approach if you're talking about out-of-hospital cardiac arrest. I think the other scientific point to bring in is that we talk about the electrical phase of cardiac arrest and then phases following that in the first 6 minutes. And if you remember on a blood gas, you take a blood gas in an oxygenated patient and your SAT is 98%. What's your mixed venous SAT? It's around 75%. We'll call it 70 to 75%. That means there's still a bit of oxygen there that can still be extracted from the hemoglobin at that point, which I think is part of the reason why one says, okay, you can get on and compress the chest because there is oxygen around in that witnessed arrest. But again, is that a hypoxic arrest? Well, then that what my argument then won't hold for that hypoxic arrest. So yeah, I think those would be my thoughts and comments around that issue.
Great, thanks. Joy, do you want to come in about the neonates?
Oh, thanks, Tanya. I think it's very, very rare that we'd ever take a CAB approach with the neonate. So we'd advocate for ABC approach, airway breathing circulation, and 9 times out of 10, a newborn neonate, you would not know if there's a cardiac cause for his arrest. It would be hypoxia related. So the aim is to get those initial breaths in within that first minute, the golden minute. So I advocate for ABC approach always in a neonate.
Great, thank you. So we have
Tim, can I put a comment in there? It's actually, one of the things we were challenged with, I'm just trying to think who I was challenged with. I might have put this onto Vido's Nakwa's desk. Was it someone in the Cape, I think, asked us, Our newborn algorithm is dedicated to the newborn that's just come out of the womb, obviously. And I think I was asked, what about the 3 days later? The child is about to be sent home or is sent home, and the neonatal rests in, let's say, the taxi. Which algorithm should they use? Should they use the newborn algorithm, or should we be teaching them the universal cardiac arrest algorithm? And I tell you, I thought about it, and I wonder if that's not an area that we need to get together and actually look at, because people are wanting to give courses to moms when they leave the hospital. In fact, this is where it was aimed from, and it's in the Cape hospitals where this came from, one of our instructors. And I thought this is a very interesting area that we should look at, because do we then need to have a neonatal phase, so that first 28 days or 2 weeks of life, I don't know what the cutoff is, where perhaps the newborn algorithm isn't appropriate, but perhaps the advanced cardiac arrest algorithm for the child and adult also is not appropriate. And I think that's something we may need to address in the near future.
Okay, and I know Mignon has something to add.
So because I like being a mediator, what I'm hearing from you, David, is that you're saying don't delay. So if I'm a patient in Shamil's ICU, I know there's an ambu bag or an anesthetic bag at every bedside, and I know I'm going to get my airway and my breathing sorted out in a flash. But if it's happening anywhere else, and I had the misfortune of having an adult collapse in front of me in a shopping center recently, and it was terrifying because you just have nothing, and they're huge. And so I think what you're saying, I don't know if there needs to be an arm wrestling competition between ABC or CAB. I think what you're saying is don't delay, get a move on and get your resuscitation going. And for kids, we know, it's mostly hypoxia, and so if you've got stuff, get going. But if not, maybe you're right, maybe start with that while you get somebody else getting your airway and your breathing stuff sorted. But I think we're kind of saying the same thing. I don't think there's that much of a difference.
Thanks, Mina and Dave. I mean, I was recently called to a resus 2 days ago when I was on call upstairs in E1. So I was the second person to arrive, and the intern was there, and he started chest compressions. I ran for the equipment. It was probably longer than 18 seconds, Dave. But often we don't have resuscitation equipment ready. So I think probably what you mustn't do is you mustn't delay starting a resus. So starting with chest compressions until you get the resuscitation equipment. The other thing I'd probably just to say is that, one of the first things when I come to a resus is asking somebody to draw up the adrenaline. And I think one day I would like to time it one day, because I'll probably say it 7 times, please, can I have some adrenaline? And it takes somebody, I don't know how long it takes, but it feels like forever for somebody to give me a dose of adrenaline and to give it into a patient. So just that asking for the adrenaline, once you get to a resus, that people can have focus and start drawing it up. Yeah, thanks.
That's great. I'm going to ask the panelists to have a look in the Q&A and perhaps start typing a couple of answers, because we have got a few questions. But then I want to give our attendees a chance. So Basitsane, if you want to unmute yourself and ask your question, you can pose that to our speakers.
Okay, so maybe while we wait, I want to ask one more difficult question, and I want to direct that again to Shamil and Dave. So if you arrive at a resus and it is a patient that has got a futile condition, like a severe cerebral palsy patient or a SMA type 1, and the parents have not been well counseled, they are present, will you start the resus and commit yourself to a resus, or will you actually rather spend time with the family counseling them? So what is your feeling in a kind of known futile situation?
I'm unmuted, Nadia. I'll take a first bite at this one, but that's a really difficult situation. And I think when you're arriving at a resus, you often don't know all the details and you don't know the situation. So I think in that situation, I think if you're not sure what's going on, most people will start a resuscitation. But equally important, it's important that somebody goes to try and find out what's wrong with this kid, who's the kid, what's the medical background. And it's very difficult if there hasn't been discussions. But I think if there's a cardiac arrest situation, and there's a child with a known lethal or life-limiting condition who's arrived in cardiac arrest, and we know that for sure, I think it's reasonable in that situation to actually limit the duration and actually stop your resuscitation and talk to family as to why you're making that call. But it's such a difficult situation, and it should be made by the most senior person at the resus. And I think if we're training people to respond to react to a resus, I think you've got to start, and then as your information starts trickling in, change the course and change the duration of your resuscitation. But it's we find ourselves in that situation all too often, unfortunately. And there is no right or wrong answer. It comes down to resources where you work, but I think that's an opportunity to not do a prolonged resuscitation.
Thank you.
Yeah, thanks. I completely agree with you, and I think there are a couple of things there. Your last point was actually the point I was going to make, is that we talk about prolonged resuscitations, and that would be one of the definite elements where there's uncertainty. So I think Joy said it at the end of her talk. If you're uncertain, you've got to start, and if you are going to start, give it your all. But how long do you go? And I think that you're quite right. So stopping then sooner rather than later is definitely advocated. But I think your question did include, futility, and you are absolutely. People think that if we don't start CPR, we're going to get sued. We're in a time of litigation. We know that, and no, that's not true. There is, because remember, it is the patient also that you're talking about at the end of the day. You're not doing it necessarily for the family. So you are covered by not starting in those instances where and a good example there are many of the traumatic arrests. You know that it's 100% mortality, and you are then covered in terms of not starting. And quite rightly, as you said, having a good neurological outcome is what we're talking about as being our aims and goals. It's not about getting the heart back. It's about returning a functional status back to the community. And so then, yes, the not to start banner is a lot bigger than what it used to be. And we saw that and if you've seen the COVID algorithms, that's what sparked a lot of our COVID stuff, because many arrests happened in these COVID patients where the mortality is 100%. And people were doing prolonged resuscitations and exposing themselves to, I'm not sure, this is not quite your question, but exposing themselves to then the possibility in the first wave of getting COVID. And so Jamil has said exactly that. The core here is discussions before. So you said it as well, is you now know that it's futile. Granted, the counselling may not have been up to standard, and so is there an entity where starting something like we said, where parents can see that there was an attempt made, so the grieving process from the parents' side may be easier, but in some of the CP cases where it is almost a relief at times, as much as I say that in completely inverted commas, and that you're going to get, I guess, from the situation that's going to present itself, then the comfort care, the dignity in death, provided that's brought across appropriately, can be not to start CPR. So like you say, very, very difficult. Core issues here are we don't have those discussions, and I've tried to even bring it into our third wave COVID ICU. Guys, let's have discussions every round on who are we going to resuscitate and who are we not. And if we're not, does the family know that? It's all fine that the doctors know we're not going to resuscitate our severe COVID in the third wave situation, but does the family know that that's what may happen? And so yeah, I think that communication channel is huge before, which isn't quite your question, sorry.
Thank you so much. I think Mignon just wants to quickly add something.
So just to extend that, so let's say you've resuscitated somebody really aggressively, and a day or two later you actually find out that they're actually brain dead, or you suspect they're brain dead, and then to go through the testing, and there again it's a place where you may have family around so they can actually watch what you're doing, and once you've confirmed that they are brain dead, then to also just remember the issue of organ donation, because there's that as well. And I think with COVID and everything else that's gone on, it's something that is sometimes forgotten about, and there are a heap of children who are actually waiting for organs as well. But obviously the most important thing is absolutely certifying the child brain dead and telling the parents that that child is dead, before you actually even move on to that kind of discussion. And that's something that maybe we don't get that much training about either.
Thank you so much. I just want to address one last question, and that is 2 questions that's in the Q&A, is about whether to intubate during resus, or whether you should actually, if you're doing good bag mask ventilation, do you postpone it until you've got return of circulation? So that's specifically directed towards Dave. So I don't know if you want to quickly just add that, and maybe also Joy from a neonatal point of view.
Yeah, thanks. So definitely not talking on the neonatal behalf. Prolonged resuscitations, absolutely. There is a time when intubation is indicated, and we know we've got the use of supraglottic devices. That doesn't necessarily mean intratracheal intubation. That can be supraglottic devices. But that doesn't necessarily mean any prolonged resuscitation must be intubated at that point. And I know we like to do it because we think we therefore are doing something more. But if hypoxia is being corrected and you are happy with your bag mask ventilation, and it's another, for instance, like I was saying to you, it's a calcium channel beta blocker overdose, and hypoxia isn't your cause, and you are winning with that, then the possibility of the disruption and the decrease in circulation and mean arterial pressure that you're getting by I'm going to try, I'm almost in, oh, sure, but sorry, okay, let's bail out and let's start all over again. Those interruptions, as much as we think they don't happen all that often, they happen all too often. And so provided you are oxygenating, because obviously if you're not and you're struggling, and there are certain circumstances, so most pre-hospital teaching that we have is that you should be able to use a bag mask device with some of your adjunctive agents and oxygenate anybody. Intubating isn't a better form of oxygenating than that method, because often if you can't by that method, how sure are you that you're going to then get the tube in, because that means is it a difficult airway for other reasons. So just remember that intubation doesn't solve a bad bag mask technique. There are a whole bunch of other techniques that you should actually work on there to improve hypoxia. But as a one-line answer, yes, in a prolonged resuscitation, sure, that you can consider intubation as long as you decrease that interruption in CPR.
Thank you. Joy, anything from your side on the neonates?
No, I totally agree with Dave. For neonates, it's very similar, though ILCOR suggests intubating by the time you do chest compressions, or if there's a prolonged resuscitation. There's really no need to rush it. If you're getting good chest rise and the baby saturating well, and particularly if you're not very skilled in intubation, do not proceed with intubation. Continue with bag mask ventilation.
Right. Thank you so much for that. So I think that's going to be a wrap. I just want to encourage the panelists, if there's any other questions in the chat, please answer that for the specific questions on your section. And I just want to really thank the panelists, to Shamil, Mignon, Dave, and Joy. I think that was so useful and helpful. And this then wraps up our last webinar of 2021. And we're really looking forward to sharing our new topics and our new webinar plans for next year, 2022. And I really hope you can all get a little bit of downtime over December from all the academics, and then we'll certainly see you last Wednesday in January for a COVID webinar. Thank you so much, everyone, and I hope you have a lovely afternoon.